Hi, lovely people. Welcome to today's NCLEX review. I did make a first video, part one of NCLEX review, and this is because I wanted to share my knowledge with you guys. I have been in the journey of trying to learn, attending online lectures. I read from my K book. I also signed up for Simple Nursing. I did a lot of studying on my own too, and I thought that it is overwhelming. It is rigorous to go through that journey alone. So I have my lecture notes. I still have the Marquee notes. I have actually two lecture notes. My actual notes I use for the preparation. And like I said in the old video, I'm going to really help you guys go through the process as much as I can. So last Sunday, I uploaded the part one video, and I am grateful that you guys enjoyed it and we're asking for more. I'm going to leave that video at the end of this video, and also I'm going to create a playlist for these videos. I intend to cover all the notes, the content I've learned, the questions, the answer, and also go through this marquee doc, the Word document that I used in preparing for the NCLEX that made me to get a very good pass on my first attempt. So yes, I'm going to leave all those in the description, but by God's grace, I'm going to be creating more of these NCLEX review to help you guys. So if you've not seen that video, I'm going to create a playlist. Let's get started. Yeah, so last video I made, we talked about other aspects. I think we did talk about a lot, which I actually recommend that you go check it out. So this is we talked about acid-base balance. We talked about alcohol, drug toxicity. We did talk about crutuches. And yeah, so now we're on lecture 5, which is diabetes and all that. But I thought that before we go to lecture 5, which is the insulin, diabetes, and all that, I think I want us to start with medications. Must know medications, those medications that you need to know for the NCLEX. Yes, I did mention, just a minute, I'm trying to get back to the diabetes and all that. Let's keep this. Yeah, we finished this. We're on lecture 5. This is lecture 4 we went through. So yes, I think the next one will be our lecture, which is the insulin, diabetes insipidus, and all that. Yeah. But I thought that it's best for me to actually go through the medications I use. Now, I paid for a course from Simple Nursing and I did write them down. So I hope that I encourage you to take your pen, take your paper. We're going to be doing a lot of writing. So the first medication we'll be talking about that the NCLEX loves to ask people about is the cardiac medication. Now, this is your exercise. Take a pen, take a paper, and draw a heart. You know, like the way we draw this heart. Yes. Draw a heart like this. Yes. And then the upper part of the heart, cross it, just put a line across the heart. And then you're dividing the heart into two. The upper part is the atrial part, and then the lower parts are the ventricles, right? So we're going to be talking about medications that help with the atrium, and then medications that help with the ventricles. So whenever there is a problem with the ventricles, remember the ventricular tachycardia, ventricular fibrillation, and remember the atrial flutter, atrial fibrillation, and all those. Yes. So in the upper part that you've divided, write A, B, C, D. So this is a very good memory trick for you to remember. The A is atropine or adenosine. Okay. Then the B is the beta blockers. And then the C are the calcium channel blockers. And then the D, the digoxin. Okay. Then for the lower part, which is the ventricle, we have the LAP, like come and sit on my lap. Yes, lap. The L is lidocaine, the A is amiodarone, and then the P is procainamide. Now, I have to say this. I encourage you to click on the caption. If you want to see the text being read out, please click on the caption. This will really help you because this video is going to take like 1 hour, 2 hours, and it's going to take a long time to start putting text. That's why I thank God for YouTube setting. You can just click on the setting on captions, and then this will be read out to you. So ABCD work on the SA node, which is the sinoatrial node of the atrium, and the function is to slow the heart rate, except atropine. Now, atropine is used for bradycardia, and bradycardia is when there is slow pulse, right? So if someone is having slow pulse and you want to increase the pulse, you give bradycardia. Okay. While the LAP, which is the lidocaine, amiodarone, and procainamide, what do? They lower the heart rate. So they stabilize ventricular rhythm, like the V-tag, the V-tag, that's ventricular tachycardia and ventricular fibrillation. Now, if you've not seen the video about the EKG, I know that it's also in the last video. We're going to be taking these medications individually. The atropine, it says it puts the heart rate really high. So the heart rate in your clients is low. What atropine does to you is like, hey, you need help? Yes, go up. So it tells the heart, they've sent me to bring your heart rate up, go up. And then it does that, it obeys. So the indication is bradycardia, that's a pulse rate less than 60 beats per minute. And so when there is low perfusion of the heart is not functioning enough, so the body is not properly perfused, that's when you give that. So cyanosis, irritability, confusion, and all that. Now, what is expected when you give atropine is that there should be normal sinus rhythm, right? Which is 60 to 100. So now we're going to the other part, which is the A, B, C. Now write this. In the A, we have the ACE, which is a cardiac medication, and then we have the APS, okay? So the ACE is the angiotensin converting enzyme, and then the ARBs are the angiotensin renin blockers, if I remember the full meaning correctly. Okay. Then the B, we're going to be talking about the beta blockers, and then the C, we're going to be talking about the calcium channel blockers, and the D, the digoxin. Okay. So everything you want to remember about the cardiac medication is the key things, the key considerations NCLEX will ask you about. NCLEX is not about how much do you know, the best nursing school you've ever been to. It is the application of your knowledge, what you know. When you have a live client, a live patient, what are you going to do? How can you spot those things that will kill the client or the patient? So considerations is that when you're given the blood pressure medication, there is a risk for orthostatic hypotension. So when they stand up, there is this sudden drop in blood pressure and they may fall. And that's why for the elderly or any patient on blood pressure medication, you have to teach them. This is now patient teaching. In the new gen, it comes patient teaching. You teach them to change position slowly. And then they must also check their before you administer the medication, you must check their vital signs. So in the pulse rate, heart rate, the blood pressure, you must check. If the pulse rate is less than 60, hold the medication. You do not want to reduce it more than that before you start calling the healthcare provider to start prescribing atropine to bring it up. So you check before giving, okay? Then that's in the systolic. If the diastolic is like less than 60, please do not give. And then if the systolic, that's the high, the upper part, is less than 100, hold the medication. Okay. So Don't lower, it is imperative to know that you are not supposed to lower the blood pressure medication. You're not supposed to lower the blood pressure too quickly. When you're treating, if you're giving a client with high blood pressure, let's say over 200, over 180 systolic, over, let's say, over 100 diastolic, your first action is not to like drop the blood pressure. You're going to do it slowly, like you're bringing it, you're petting it down. Like, yeah, I know that you want to be up, but let's go down slowly, not like you crash it down, because that can lead to hypertension, confusion, and so many side effects. Okay, so now we're going to go to the apps. So the apps and the ACE. The ACE and the apps. Now, I did mention medications that cannot be used for pregnancy. I don't know if it was in the last video. If it is not there, I have been scripting this NCLEX review. If it is not there, I'm going to be talking about it soon. So watch out for that. But one thing about this blood pressure medication, the ACE and the apps, angiotensin converting enzyme and the angiotensin renin blockers. One thing you should know about them is they cannot be used for pregnant women. Never contraindicated. Now, I will be mentioning this point, and I hope you write them down, because the things I'm trying to mention are the things that NCLEX really tests you on. So very important. Now, the ACE, the ends with the pril, like enalapril, captopril, but then the apps are the stans, like cadastan and all that. Now, the first point, what clients receive from healthcare providers are the ACE first, the angiotensin converting agent, which and the end with the prils, enalapril and all that. But then cadastan will be given when there is side effects to the ACE. Okay? So some of the side effects are the cough. One thing about the enalaprils, captopril, they have this nagging cough, like patients just start getting the medication, is working, but then the side effect is cough. So when the healthcare provider changes the captopril, the ACE, they change it to apps, which are the cadastans, the ones that end with stan. Okay, so it says check first time user. Is this very important? Now, I need to add this about potassium. Potassium, we know it is a very high priority lab value. And the ACE, they spare potassium. So because they spare potassium, you should actually check the volume. Some people take potassium, a lot of potassium, like the banana has a lot. So it's better that you check. And also the apps, both the ACE and the apps, they spare potassium. So you don't really have to worry about them losing potassium. Okay. So for things you need to remember about the ACE and the apps is that you have to check first time users, because the blood pressure may drop too fast. And remember, we don't want to drop the blood pressure too fast. So you need to like observe them. Then the thing is, when they're alone, you have to call them. You have to tell them to use the call light, because you want to have like close observation. You don't want them to just stand up and fall when they're trying to use the restroom. And one thing I remember, I told you that the ACE and the apps, they spare potassium, which means that there is high chance of hyperkalemia. Remember, our lab value is 3.5 to 4.5. So 4.5 and more is hyperkalemia, and we don't want to have that. So it's important that you check the lab value. Now we're going to the next blood pressure medication, which is the beta blocker, and they end with LOL. That's laugh out loud. So if this helps you to remember, LOL, like the bisoprolol and bisoprolol. Leave in the comment section some of the beta blockers you know Atenolol, bisoprolol comes to my mind because that's what I really give my clients. Atenolol, these two, they're the ones on my mind. So as always, for the blood pressure medication, you need to check the heart rate. You need to check the blood pressure before giving. You're not checking after. You want to assess, our nursing process. You first of all assess before you give a care, right? Okay, so the side effects, like other medications, is that there is orthostatic hypotension, so you teach them to change position slowly. There is high risk for bradycardia, so less than 60 beats per minute. And they can also cause bronchospasm. And that is why these medications cannot be used for people with heart failure. Very important. Other medications can be used, but when you see atenolol, bisoprolol, and then this client has CHF, that's the um, chronic heart failure. You're like, healthcare provider, I just checked the client's history. I don't think this is the best medication for the client. And yes, so for people with breathing difficulty, respiratory problem, lung problem, and heart problem, these bisoprolol, that the beta blockers, are contraindicated. Now, how do you know the worsening heart? There are indicative, like classic manifestation for chronic heart failure, right? We have the edema, that we have the weight gain, and then we have the crackles, we have distended jugular vein, like it shows the vein here is just like enlarged. Yeah. Okay. So let's move on to I think this is the fourth one, which the calcium channel blockers. These ones end with the pine, but then there are some brothers that don't want to bear the surname, which are the Pamil, like verapamil. Usually, when you see the calcium channel blockers, you see like nifedipine, amlodipine, and all that. But then the half brother is there, which is the verapamil. It is also part of the calcium channel blocker. As always, check the blood pressure, do the patient teaching, and by the way, dithiazem too is part of the calcium channel blocker. So safety precaution is assess heart rate, check blood pressure, avoid sudden drop of the blood pressure. Even if we want to reduce the pressure, the blood pressure that is high, we don't want it to crash. Then we'll move on to digoxin. Digoxin, we've talked about drug toxicity, and we said that anything over 2.0 is bad. And we talked about digoxin manifestation, things to assess for when you want to know if now the digoxin level is too high, is being toxic. The manifestation, remember, we talked everything about the vision changes, green halos, difficulty reading. Clients may tell you, I'm looking for my glass, but all the time they are wearing their glasses. Patient is reading with glass on, but they're like, for some reason, I cannot see. That's a sign of digoxin toxicity. I mentioned that in my previous video, so please check that out. And of course, in in drug toxicity, the nausea and vomiting is always there. Okay, so yeah, it is important to check the apical pulse. You hold medication if the heart rate is over is less than 60. Okay, and one thing about digoxin is that it can cause that, well, hypokalemia, low potassium level, can potentiate digoxin toxicity. Now, it does not, digoxin does not really cause hypokalemia, but the fact that a patient has hypokalemia, low potassium level, less than 3.5, it can increase the tendency, can make digoxin toxicity more, right? It can worsen it. So you have to teach them to avoid, or if a client has potassium wasting medication like our diuretics, very good example of these diuretics is furosemide. If they have that, you have to inform the healthcare provider about it. Like, those are the loop. Yeah. Okay, now that brings us to diuretics. We have the two types. We have, for me, I don't know if you guys can see these. Let's see. Good. On the diuretics, I like diuretics. here is potassium sparing. The other part is potassium wasting. So we'll start with the potassium wasters. That's the end with the I, furosemide, hydrochlorothiazide. But then the potassium sparing are the actones, spironolactones, everything that ends with actone, right? Now, you have to monitor, like we said, we have the potassium sparing and the potassium wasting. For the potassium sparing, of course, you need to check so that as you give, it doesn't get to hyperkalemia. But then very important is the potassium wasting. Potassium is a very high priority lab value, so you need to check when your client is on furosemide. So you may monitor potassium level. It should not be less than 3.5. And one thing about furosemide, I think this came in my actual NCLEX examination, is that it causes ototoxicity. So there will be problem with the ear. There may be tinnitus. There may be hearing loss. So you need to actually check. Now, the first drug of choice whenever there is heart failure, chronic heart failure and all that, is furosemide. Like if you see someone with sudden weight gain, crackles in the breathing, well, when you listen to the lungs, there are crackles, there are distended jugular veins and all that. One thing you should tell your healthcare provider is, I have assessed after you've done the XBAR, right, assessment, what you should expect. NCLEX will ask you, what would you expect in the new gen, those bow tie question. This is the condition, the signs and symptoms, which you see the crackles on breathing, you see weight gain, you see edema, usually the pitting edema. But then what to act, what to do, or what to expect. Actually, they ask that question, what to expect that the healthcare provider will be prescribing is furosemide. That's the first drug of choice. If you're not remembering anything about diuretics, remember this. Furosemide, loop diuretics are the first drug of choice in treating chronic heart failure. Okay. Yeah, things I have already explained everything that I wanted to say. Yes. Okay, then let's go to the potassium wasters. We have in the wasters, you teach them to eat potassium rich food. They are not supposed to avoid it, but let them just eat in moderate. Everything is temperance, right? Moderation. So the green leafy veggies are the ones that are packed with potassium. Sometimes NCLEX may ask you foods that are packed with potassium, and avocado, banana, strawberry, potatoes, orange, melon. And you're encouraged, like you can encourage them to use salt substitute, but without potassium. There are salt substitutes without potassium. And then when we're talking about spironolactone, they are the ones that spare potassium, right? In Finland, there is this licorice people take, and you have to tell them to avoid licorice because it can actually lower the blood pressure. So if your client is on diuretics, furosemide, hydrochlorothiazide, tell them, you see this licorice candy you're having is not good for you because it's going to make the potassium that is already lowered by the furosemide is going to lower it more. So you tell them to avoid those. That's if they listen. Okay, so for the potassium spares, you monitor for high potassium level. And when the potassium is high, in hyperkalemia, on the EKG strip, you will see peaked T wave, ST elevation, right? Okay, so in the potassium sparing medications like the spironolactone, you tell them to avoid potassium-rich food. And well, if they want to eat licorice, they can go ahead. And also, they should avoid salt substitute because that will actually save potassium. So 5 safety tips you must remember for the NCLEX. NCLEX is about safety. It is a safety examination. So the number one is you give diuretics in the morning. Do you know why? It's best for the kidney to excrete morning, afternoon. But then if you give in the night, there is risk for fall, because in the night, the patient will be sleep deprived, sleep poorly, and then with sleepy eyes, they may try to find the toilet, miss their way, fall. It compounds the problem. So it's better to be given in the morning. Even when you check on the prescription and you see diuretics, furosemide, and all that in the evening, you have to question that. You have to ask the healthcare provider, do you mean in the evening? So it is usually given in the morning. And of course, slow position changes. Also, there is daily weight measurement. Now, when the NCLEX will ask you about measurement, not just for the blood pressure medication, but also for everything relating to weights, the best option to choose is not weekly. Now, when you're answering the question, please read between the lines. NCLEX is very good at hiding the wrong things. One word can make a seemingly right answer wrong. So they will say blood check or measure the weight. But then if they add weekly, that's why you need to read. If they add weekly, then that's wrong, because there may be sudden increase in weight, but then you cannot tell in a week. So it is better daily, daily, daily. As long as daily is not there, it's wrong. Even if it is a good thing to do, but it has to be daily. And then you can keep patient on cardiac monitors. Why? Potassium. Potassium is a very essential. It pumps the heart. That's what I used to remember. Potassium P pumps the heart. Everything relating to the heart. If the heart is not working, there is no patient. Patient is dying. There is no cardiac perfusion. From no cardiac perfusion, no oxygen, organs are not deliver the food they need to survive. Brain damage, loss of patients. It compounds, right? So one thing about the weight that I need to add is that um approximately 2 to 3 pounds in 24 hours and 5 pounds increase in weight in 7 days is a cause for concern. Remember, when there is water gain, there is weight gain. Now we're going to go to the vasodilators. Vaso, blood, dilators, open, right? So look for the O's like the nitroglycerin, the nisoprusside, and isobabide. Isobabide, isosobide. Yeah. Okay. So they open up the blood vessel, and by opening it up, they reduce the pressure the heart had to work with. So open up the blood pressure, and then you lower the blood pressure, right? They open up the blood vessels, I'm sorry, and then by thereby giving freeways like a congested part when it's slow, when it's like tight. So when the isosobide, the nitroprusside, and the nitroglycerin come, what they do is like they open the blood vessels, then blood can flow more, and then the pressure at which the heart is pushing is now lowered, and that's where you see it reflected in your measurements. Okay, so safety precaution. When the blood pressure is low, you gotta go slow. That's changes in position. And because nitroglyceride lower the blood pressure, you have to teach patients to go slowly. That is everything about the cardiac medication. Very important. Now, something you have to teach the male clients is, you see sildenafil that they use in arousements, right? Yes, you teach them. When my clients come in and I check their list, as for a man, if they're coming to say give me sildenafil, I'm going to check their prescription to see that there is no nitroglyceride. Because if there is, guess what? You're killing the client. You are killing the client. So yes, um, sildenafil will kill the client for taking. Yes, Nclex always ask this: when do you stop nitro? When is below 100, just like every other medications, or when there is a drop by 30 or more. So headaches are normal in clients taking nitro. They are just expected side effects. You're not supposed to call the healthcare provider about that. Now we're going to go to antibiotics. I have done the aminoglycoside with you guys in the last video, but now we're going to go to most known things, safety precautions with you. Remember, we talked about the peak and the trough when we're talking about the aminoglycoside, gentamicin, neomycin, and all that. Now we will talk about the safety precautions. Teach patients to finish their medication. Very important. You don't want them to get tolerance. You don't want them to get resistance to those medications. And you don't want them to have those MISA, MRSA. You don't want them to have that. Then for accidental pregnancies, you have to look for C's like penicillin and tetracycline. Oral contraceptives, when they are taking medications, are not really effective. So you need to check if they are pregnant before giving penicillin or tetracycline. And when they have antibiotics going on, you have to inform them that there is a need for additional contraceptive because they may likely get pregnant. So they can use the IUD, that's the hormonal one, or use condom. If not, they are getting pregnant. Okay, so mixing. There are medications you cannot mix, right? So like cephalosporin and the cyclines, the tetracyclines, they cannot be mixed. So penicillin, cephalosporin, never. Okay. So if patient is allergic to penicillin, then there is a likelihood for them to be allergic to cephalosporin. Now, example of this cephalosporin, we have the ceftriaxone, we have the cephalexin, and cefazolin. Now, tetracycline, NCLEX may ask you about patients teaching. Either they are going home, they are at home, or at the bedside at med-surg ward. So cycling on a bike is not safe for pregnant women. I mean, this is obvious. You don't encourage a pregnant woman to be cycling, right? And that's antibiotics. When you see client come in, there is this discoloration, those antibiotics cause. And then in summer, it is imperative to teach them that you cannot enjoy the sun without sunscreen. So it is even better if they avoid the sun because these medications are sensitive to sunlight. So they should wear sunblock. Okay, some of the things that antibiotics to avoid or antibiotics that you have to teach your client to avoid sun exposure to are the fluoroquinolone, like the levofloxacin, tetracycline, and the sulfur medication, sulfonamides. I remember one of my patients last week was prescribed sulfonamide, and the doctor actually did my work for me. She's like, yeah, we know it's summer, but please avoid the sun, wear your sunblock and all that because they are sensitive to sun. So remember these three. What I use is the FTS not good for sun. F is the that's a mouthful for me, fluoroquinolone, that's levofloxacin. Then the T is tetracycline, and the S is sulfur medication, sulfonamide, sulfate, everything with the sulfur thing, right? Now, let's talk about the sulfur drugs. Like we said, sunburn, avoid it because it can actually cause sunburn. Then it can cause urine crystals. And one way to avoid those urine crystals is to encourage them to drink a lot of water. In fact, every medication, what I tell my clients is take a full cup because people are used to just like taking a sip like it's wine when they're drinking medication. You encourage them to drink enough to help their kidneys excrete those excess from the body. And yeah, they should actually take folic acid when taking sulfur medications. And of course, sulfur medications not recommended, in fact, contraindicated for pregnant women. Now let's go to metronidazole. Metronidazole, like those bacterial vaginosis, they are used in the treatment of those bacterial vaginosis and other medication, other problems relating to the skin. So metronidazole, I think the one of the trade names I remember is Flagyl. In Nigeria, we know that medication, Flagyl. So they have deadly toxic effect, which is skin peeling. Like when you know that those medications your patient react to them or contraindicated to your patient is this peeling of the skin and then rash. You know, Steven Johnson syndrome, that is also a part of reaction to a particular medication, swollen face, redness, and all that. I did take care of a client that was like 13 years ago when I was a student nurse, and it wasn't a pleasant sight. So you also tell them to avoid me, not me, like me, but if this helps you to remember, is they should avoid alcohol. And yeah, and the M there is the rash. Once there is rash, they should stop taking the medication. Now, we did talk about the aminoglycoside, which we said that they are the big guns. They are used to treat bone infections, skin infections, like those medication, those symptoms or those problems that need a medication to kill the bacteria, right? And we talked about vancomycin, neomycin, and all that, and checking the drug toxicity level, which is for the vancomycin over 20 is a red flag. And we also talked about if those aminoglycoside they end with mycin, right? But then if there is throw in them, it means you should throw them away from the list. That's what Maki actually said. And that's what I used to remember them. Like erythromycin, azithromycin, those ones are now used to, those are the ones actually used to treat chlamydia, right? So they are not part of the aminoglycoside. But one thing I want to mention about this azithromycin, erythromycin, apart from the fact that they are used to treat chlamydia, some of these sexual transmitted infections, you need to monitor their EKG. Whenever you see anything on NCLEX, apart from throwing them away, remember EKG. This actually comes a lot in exam questions. So anything throw, monitor EKG because it can cause prolonged QT wave, right? Now let's go to the respiratory medications. Terms to look out for. We have asthma, coughing, wheezing, shortness of breath. They are indicative. They are classic manifestations of everything relating to the chest. Okay, for people that have asthma, it is important you teach them to take their inhaler 15 minutes before exercise because by then the medication must have, in Finnish, they say vaikuta. What is that? Has become effective. Yes. So when there is low oxygen level, like the asthma, which is an acute condition, or COPD, that's when you will use that. Now, I encourage you to actually draw like you did on the diuretics. Write a mark. Can you see this? Yeah. So respiratory, and draw two lines. The first one is to dilate. There is one to dilate, and there are others that are anti-inflammatory. Now, 4 drugs you need to know for the NCLEX that are related to respiratory medications are first one is the albuterols. Now, albuterols are, if you think of A. So albuterols, asthma, they go together. First name albuterol, surname asthma. That's a very good memory trick. I think these are those memory tricks I use to remind myself. Albuterol, they are the first medication. If someone is having an asthmatic attack, first thing you give is albuterol, right? They are called the rescue medications for the acute asthma attack. And the albuterols, they dilate the bronchial, right? And normal and expected side effects is they can have tremors, they can have tachycardia, and they can have restlessness, like they can be turning and tossing all through the night. These are normal side effects of the albuterol. Now, one thing you need to remember is you have to shake the the inhalers before giving. And the thing very important is you don't give this medication after others, because the albuterols, they are there to dilate. It's like they are preparatory medications. So you're giving to open up the airway, and then you can give the medication that will stop the process or will care for the process. So albuterol should be given before other medication, because obviously they prepare the way for other medications to be easily absorbed. Okay, the second medication you should know is ipratropium. Ipratropium, Apatropium. I don't know if I'm pronouncing that correctly, but the ipratropium means you cannot pee with a tropium. It means that they hold the bladder. It causes dryness. They are anticholinergic drugs, so they dry out the body. When you think of dryness, dehydration, it means patient teaching. You have to encourage them to take water. So anti-secretions, anticholinergic, like that's what they do. They just suck out the water, dry you up. So they can lead to fluid retention problem, bowel obstruction, glaucoma. So all these things are contraindicated for clients that have those. And yes, for male that have, or male clients that have big prostate, that's the BPH, benign prostate cancer, you have to avoid that. Encourage fluid, and you should never swallow tropions. They should be crushed in the inhaler device. Okay, then the third medication are the steroids. You must have seen those steroids like the prednisone, fluticasone, beclometasone. They are the anti-inflammatory medications. So they are slower to act, and that's why they are like they are not rescue medications like the albuterol. They are the caring ones. Things we call the hoitavalake. So they care for for the lungs, and they help to reduce the swelling. But then, like other steroids, they have risk for infection. So whenever you think of steroids, the beclomethasone, prednisone, think of high risk for infection. So it is better to use spacers to reduce infection. That's why you put the inhalation through the spacer. I wish I could show you guys those things. And then, apart from the fact that it makes the medication to be readily available, like you don't lose so much using the spacer. The other thing is that it prevents infection. And now, whenever you think about the steroids, remember to encourage them to rinse their mouth after using the inhalers, to avoid oral crush, to avoid those infection, right? And also, the because you're using spacer, the one around the mouth, it is good, like when you put the spacer into the mouth, right? This, so if this is the inhaler and you have the spacer, you clean that mouth so that they don't use the same thing over and over. And yes, rinse and pour out the water. Very important. Some of the old clients I've taken care of, they are like, oh yeah, there's water. And then they swallow. No. Tell them to pour it out. It is best that you take two bowls or two kidney dishes. You give them, or just one kidney dish, right? Give them the cup, the gargle, and then offer them the kidney dish to pour the water into. Okay, so management of asthma attack. The right order is to aim. The aim is A, which is albuterol, the rescue drug that opens the lungs or dilates the bronchus, and the ipratropium. And then the last thing is the one that cares for it, which is the steroid, methylprednisolone or prednisolone. Then we go to another respiratory medication, which is the theophylline. Now, the theophylline, they speed up the heart rate. Remember, theophylline over 20 is toxic to the body, right? Um, Theophylline gets you feeling caffeinated, too much energy boost. So they can cause tachycardia. And yeah, one of the things about, remember when you say theophylline, one thing I used to remember is the tonic clonic seizure, because it just, the energy is too high, it gives you too much energy, like you've drank coffee that has caffeine in it. So there is this high hyperactivity, right? And it can cause tonic clonic seizure. So you need to take frequent blood draws to be sure that the level is no more than 20. Okay, now we're going to go to the immunosuppressant and the chemo medications. We have the mode of action is to suppress the immune system, and they inhibit really they inhibit new cell growth. Okay, so these chemo drugs, they suppress cancer cells. Chemo, remember cancer. And by suppressing, they suppress cancer growth, they suppress tumor growth cells, and they suppress the bone marrow where the white blood cell are being made, are being produced, resulting to low defense. Yes, there are good things about these medications, but one thing you should know when we talk about chemo medications, immunosuppressants are risk for infection, because as they are suppressing, well, the bone marrow is also a body cell, right? As they are suppressing other cells, they don't go and like pick. It's not like a buffet, they pick what they want. It's like everything is exposed there. So what they do is they just reduce the growth, suppress the growth of every cell, meaning that the bone marrow that produces the white blood cell will also be reduced. The function will also be reduced, meaning that they will be exposed to infection more than the normal patients. So, because of that, any low grade fever, usually if they have a fever of 36, you have to 36.5. Let's say that's normal. But when it gets to 37 and they have immunosuppressants, you're like, okay, something is getting wrong, especially when it gets to 37.5, close to 38. No, that's in it is also, once it gets close to 100, actually the NCLEX uses in Fahrenheit, not Celsius, right? So once it gets to anywhere close to 100, remember this in low grade fever, 100.4, you have to raise, is a cause for concern, because they may be having massive infection. And then the change in the red blood cell and the white blood cell can lead to high risk for bleeding, right? And of course, these immunosuppressants, they are contraindicated for pregnancies because they could just suppress the growth of the baby. And yeah, low immunity, low infection, low platelets, bleeding difficulty. So it's not just the exposure to infection, but also the risk for bleeding. So the safety precaution, very important, please. I hope you're writing, because NCLEX, they look for the bad things, the things that will kill your clients, and they're like, do you know how to save your client? Do you know how to keep your client safe? NCLEX is a safety exam. If you've not seen the video about what I did, the strategy to pass, I'll link that also in the description. I think this is a good time for me to take a pause to say, please help me. I think now my kids are sleeping. I should be sleeping. My channel is not even monetized. So I really want your help. What can you do? Send this video to somebody that you know is preparing for NCLEX. It's that simple. Do your own part. Pay it forward. Don't watch it alone. If you have a group, if you're in a WhatsApp group, I was once in a WhatsApp group, and I would have been so grateful for anyone that had taken the time to share the video. Share this individually to your WhatsApp group, to Facebook. Please share this video so that others can see it and also learn these concepts, right? And then please click on the like button. Just below the title of this video, there is this thumb up. Give it a like, because it tells YouTube that, oh, this girl has done a good work. and they will send this video to other people. You don't even have to do anything. Just clicking on the like button tells the algorithm that, okay, more people need to see this video. And please leave a comment. You can actually be writing your notes in the comment section. Please leave a comment for me. I'd love to know how this video is reaching you, what videos I need to do more. I have a plan, but I may actually include that in the plan. Leave a comment for me. Just please leave a comment for me. And if you're not subscribed already, please subscribe. I do have an ebook that talks about how to move to the US as a as a foreign educated nurse. I have an ebook on how to thrive, and I also have more like the gold standard for NCLEX. I have the HESI. I have other resources that I may not even be able to go through. In my description, I'm going to leave the link on how to access them. They are all for free. I have collected them in one, and I will send that directly to your email. So if you want that, please check the description for the link. Okay. So let's go for the safety precautions when it comes to clients that have immunosuppressants. No fresh fruits. So those fresh fruits may have those things that can increase infection. So no fresh fruits. Sorry, during summer they cannot have fresh flowers. If they come to the nursing station, like visitors come with the nursing station, come to the nursing station with those, please take the flowers away to keep your client safe. And no live vaccine. So the live vaccines are the TB, the smallpox, the rotavirus. They cannot take live vaccines, right? And to avoid bleed risk, they should use soft brittle brush. NCLEX loves asking about this. Bleeding bleeding risk, soft brittle brush. Avoid aggressive brushing, and avoids bumps and cuts that could actually lead to big bleed. Now, for the chemo drugs, very important for NCLEX, we have the doxorubicin and the cisplatin. For the immunosuppressants, we have the hydroxychloroquine. Whew, that's a mouthful. Hydroxychloroquine, the methotrexate, and the cyclosporin. Now, for the hydrochloroquine, remember hydro. Some Yorubas or there are some people that mention high like I. So remember hydrochloroquine, that's hydro, they affect the eye because they damage the vision. They damage the eye, leading to vision problem. That's one thing you need to check when giving those medication. Methotrexate not used for pregnant women or people that have just had transplant, bone transplant or kidney transplant. And yeah. Okay, so cyclosporin, they can they are used after transplants to prevent organ rejection. I did have a client that had this both kidneys transplanted to him, and yes, he was on cyclosporin. So the memory trick is that in the cyclosporin, it spares the client from organ rejection. This is the memory trick I use to remember these things. Okay. So the big lows, low immunity and low platelets, that's clotting. Now let's talk about neutropenic precautions, which are the safety precautions we talked about. That's no fresh flower, no fruit, low grade fever, cause for concern. Anything close to 100 is a cause for concern. Frequent eye examination. Remember our hydrochloroquine, yeah, which is a hydroxychloroquine. Yeah. So this should actually go to eye examination frequently during corona or wherever they are. They should avoid big crowds. So that's why those people on cancer medication, they are encouraged to avoid going to events that have so many people. No reason for shaving. Remember the bleeding risk. No immunosuppressants, no use for pregnant women. Avoid live vaccines and extra precaution. Like they just have to be very cautious. Okay. Now, Let's talk about antacids. Antacids are those medications that we give for ulcer when there is a high acid in the body. So it is important that they should be given alone, like those medications should be taken alone. There is no need to take food, so not with food because they interfere with other medications. But then if there is, then your client may ask you, is it that I'm not taking any medication, any food ever again, or any medication? You have to tell them that you can give the medication 1 hour before other medications, right? You can give antacid 1 hour before other medication. But if they've taken other medications, then they have to wait for 2 hours before taking it. Okay. Steroids. Simple Nursing. This is a course I got from Simple Nursing. It says the steroid helps the body to respond to stress. So in stress, the body needs a little bit more, a little bit of more sugar. So the immune system gets a little lower in terms of stress. Steroids help the body to adapt to stress. So example of these steroids are the zones. There's amectazone, hydrocortisone, fluticasone, and prednisone. Now, safety in steroids, the memory trick is that everything is. So steroids increases the infection rate. Very important. Although it helps with relieving stress, but then it exposes clients to infection. And also there is hyperglycemia. And that is why when clients are hospitalized, there is increased stress, right? And then the wife may ask, or a patient relative may ask you, my husband in this case, for instance, or my son is not diabetic. Why are you giving insulin? That's because when they're in the hospital, the stress is usually high, and there is this high glucose level. That's hyperglycemia. So even if they are not eating, you need to give them the insulin. I hope this helps you. This actually came in one of my exams. I don't know if it was when I was preparing for the NCLEX or my actual NCLEX. So it is very important to remember this. And yeah, so one thing you should remember about the steroid, not just the stress, but also that steroid on its own is packed with sugar. Just remember that it's packed with sugar. Not really, I can prove that, but then it's a memory trick for you that it increases sugar, the blood sugar. And of course, it leads to swelling, weight gain, water retention. So steroids make the body swell. Remember the disease condition and disease and all that? We'll get to that. Maybe not in this video, but in subsequent video, we'll talk about that. So steroids can actually cause mood changes if there is low-grade fever reports, low blood infection rate, like the white blood cell, less than 5,000 reports. It can also lead to fracture, osteoporosis, and cause side problems. So one thing about steroid is that you cannot stop it abruptly. So they need to be tapered off slowly, never abrupt. Okay, let's go to the pain medication. This is almost 1 hour. Maybe we'll have to do this video for over 2 hours, 3 hours. Let's see. I'm feeling sleepy, but let's continue. Pain medications, we have the NSAIDs. We have the naproxen, ketorolac, aspirin, indomethacin, and then we have the ibuprofen. So the NSAIDs they are used to treat pain. They're used to treat inflammatory pain and fever, right? Now, one thing you should know about the raised aspirin, these actually came so many times when I was doing my practice on Uworld. One thing you should never do is give aspirin to children. Never give aspirin to children. Why? Because it may cause Reyes syndrome. The Rey is Reyes, Reyes syndrome. So tell the patient, tell mothers, even when mothers to our come for my care, come for me to care for the children, I tell them if they have fever, if they have ear infection causing pain, whatever thing they're having, never give aspirin. You can give them the ibuprofen, you can give them paracetamol, but never aspirin. Okay? So, long-term NSAID, the Burana, ibuprofen, ketorolac, naproxen is not recommended. I mean, for emergency situation, for when it's happening for a short time, it is okay. But like long term, it is not okay. The other thing is you cannot give NSAID to people that have bleeding problem, right? So if they have ulcer, they've gone for surgery or anything that relates to GI bleeding, it is contraindicated. And the NSAID actually wasn't asthma attack, there wasn't heart failure, there wasn't renal failure. Okay. So safety precautions for this NSAID, knowing what they do, is never give these to peptic ulcer clients. Whatever kind of ulcer, GI ulcer, never contraindicated. And it is not for chronic use. Like when you have pain, the first thing you should go for is not like the NSAID. Well, you can use it 1 or 2 days and so, but like continuously chronic, give them paracetamol instead. And never on empty stomach. Tell them to eat, tell them to drink water, then they can have the NSAID. That's the naproxen, ibuprofen, indomethacin. So they should always take with food. And just peradventure that they've taken the medication, you also want to assess that there is no GI bleeding, there is no side effects. So you need to check the stool. Is it black tarry? You also need to check for when they vomit. Is it like coffee brown vomit, MSCs? So it is very important all the time to give paracetamol instead of NSAIDs, right? Okay, brings us to our paracetamol, which is the acetaminophen. NCLEX is trying to use the brand name, not necessarily the trade name. The trade name is Tylenol, Panadol, paracetamol, but the brand name that NCLEX is using, especially in this new gen, is acetaminophen. Okay. So one good thing about the acetaminophen is that there is no bleeding risk. Unlike the NSAID that there is bleeding risk and all that, there is none for this. But then it can cause liver damage. It's not like all rosy. It's not without fault. One thing you should know about the medication, paracetamol, is if they have liver problem, liver cirrhosis and all that, it is not good for them. Okay, remember to check the liver levels then when they have acetaminophen going on, the ALT and SPT. I'm going to be talking about that in a minute, but safety precaution, don't give to clients with alcoholism, because with alcohol, liver. Alcohol is metabolized by the liver. So if they already have a problem with the liver, it's better not to give to them. Acetaminophen or ibuprofen to kids, to hemophilia clients with bleeding risk, give acetaminophen. Yeah. So we are going to remember if it gets to the toxic level that, oh yeah, now I was not able to control it. There is an antidote. Remember the antidote? I'm going to pause for you to say it. Yes. The antidote is acetylcysteine, which is a medication used in cystic fibrosis. When the body produces a lot of mucus that the pancreatic enzymes cannot really digest the food. So that's the medication it's used for. So let's go to opioids. Must know opioids. One of the things you know about it, you must know about it, is the antidote, which is Narcan. That's a trade name, but the brand name is naloxone, right? So, one thing you need to know, remember, that comes to my mind every time I think of opioid. Yes, it helps relieve the pain. Yes, it's all rosy. It's just like the magic wand you flip, you shake, and the pain disappears, right? But then it leads to respiratory depression. So you have to be careful with people that are already respiratory depressed, breathing difficulty. You don't give opioids to them, because they can lower heart rates, lower blood pressure, they can lead to low brain function, constipation, everything low, like hypokalemia, lowering of everything. So oxycodone, hydrocodone, morphine, fentanyl. Now let's talk about fentanyl. Fentanyl, we have the two parts. We have the patch, and then we have it in the pump, the IV pump. The patch is the one you use for a very long time, the one you can put on the patient's back for pain relief. Usually, sometimes you change it once a week, sometimes you change it usually once a week on the same day on a dry skin. But then the pump, that's the PCA. One thing I remember about this, having done a lot of this NCLEX review while I was preparing for mine, is that the patient controls it. You as a nurse cannot tell. Pain is subjective. Patients will be the one to say, I have on a scale of 1 to 10, 10 being the highest, 0 not at all. I have 8. So you as the healthcare provider, you as the nurse cannot control the PCA. This is like a bonus point that I remember off my head. And it is usually given after surgery. Oh, yeah. So let's talk about the PCA. I said only patients can push the button, not the nurse, not the family, not the HPC. Sometimes NCLEX can ask you those questions to ask you to know if you know it. And it is important that you constantly do the pain assessment. How? That scale I told you, using the pain scale, right? Even through observation, you look if there is guarding in one part when they move, or twitching of the face, or verbally when you do the 0 to 10 and they say 8 over 10 or 1, something like that. And yeah, so it is important to teach the client that they are the only ones to press it, because some of the clients will be waiting for you, like, my nurse have not given me medication. Tell them, press it by yourself, because you're the one to know at what point you need more of it, right? So the fentanyl patch is not for acute pain, because it takes a longer time for the effects to be out. And it should never be placed on a broken skin. Always a dry, normal, tear free, broken free skin. And yeah, it is used on a clean, dry skin, and it is not, well, it is for a long term or chronic pain. So naloxone, remember when I was talking about drug toxicity, I mentioned that naloxone is the antidote, but the one thing you should know is that the effect wears off very fast. So when you give the naloxone, you may have to reassess and give again, usually about an hour, 30 minutes to an hour. Now we're going to go to muscle relaxants. They relax the muscle, they lower heart rate, that's their function, the lower blood pressure, the low the blood pressure and brain function. They can also cause respiratory depression. Example of these medications are the cyclobenzaprine, and the baclofen. Okay, memory trick is in the baclofen, think back in baclofen. So they put patient on the back. It means that they are sedative. So you can never stop these medications abruptly. Anything that work on the brain to stop sedation should be stopped slowly to avoid problem. So they should avoid alcohol. Alcohol is already lowering the consciousness. So you don't want to increase the sedative condition. So in these ones, they cannot drive. Benzodiazepines indication. They do three things: calming of the nerves, which is the anxiolytic, anti-anxiety. They are tranquilizers, meaning they make you sleep for those people that are sleep deprived, and then they are anticonvulsant. Now, one very interesting thing is the first drug of choice for epilepsy and all that, is this benzodiazepine. Okay, so rectal diazepam can be given to kids when they have seizures. Very important. So let's talk about the mode of action, that they potentiate the endogenous GABA, a neurotransmitter that decreases excitability of nerve cells, particularly in the limbic system of the brain. NCLEX will not be asking you the mode of action, but they expect you to know the safety, they expect you to spot the medications, they expect you to know when to use them. And they usually end, I love benzodiazepines because they are just straightforward. They end with PAM or LAM. So we have the clonazepam, diazepam, lorazepam, flurazepam, aprazolam, or midazolam. Now, one thing about those benzodiazepine, the antidote if they become toxic in the body is flumazenil. Okay, so benzodiazepines, they are also used for alcohol withdrawal because they are tranquilizer. In alcohol withdrawal, there is this excess irritability, seizures, and all that. So the symptoms of this are like when they have tremors, anxiety, sweating, palpitation. This is when you give diazepam, midazolam, and all that. So their benzos are drug of choice for patients undergoing alcohol withdrawal. I just said that. So side effect is that they have anticholinergic. When you remember anticholinergic, remember the apotropam dry. They're dry, like anticholinergics, they lead to dryness. So, but the side effect of benzodiazepine is dry mouth. Actually, you can use ABC. The A is anticholinergic, which leads to dry mouth and urine retention. Then the B is blurry vision. The C is constipation. And then the D is drowsiness and respiratory depression. Depression, in this case, respiratory, not like general psychological depression, but breathing difficulty, breathing depression. Okay, so it means that when those medications are being given, you need to put the saturation, the oxygen saturation, on the finger to check that they are not depressed. Benzos, just like the NSAIDs, just like the steroids, they cannot be stopped abruptly. They should be tapered off gradually. And just like antidepressants, this is to prevent rebound syndrome. Okay. Here, we will go to antipsychotic medication, but I want to first of all finish other medications because antipsychotic medications are medications you must know. Like they come. If you don't know them, I will be tempted to ask you, what do you know? Because the NCLEX, they love to ask about that. And that's because most people are depressed. In this developed country, depression is real. So you will always, you will have a client with on this antipsychotic medication. So the NCLEX wants you to know what you need to know about, what you need to do about these. Okay, so let's start. I could actually go ahead, like now write this. I have written it in my notes. You need to know this for the NCLEX. I could actually, let's see if I have done this first. Yes. Okay. I will talk about these antidepressants later, but I think that there are shorter topics we may be able to cover with before the antidepressants, which are, let's talk about that. We have the histamine blockers and the proton pump inhibitor. The histamine blockers, that's the histamine 2 antagonists, they end with tidines. Tidines is like the ranitidine, if I remember. Yes, ranitidine, famotidine, cimetidine, and nizatidine. So what are they used for? For allergies. I actually have these spring allergy. So I use the desloratadine. And then but one thing you should note about this is that this semetidine is not the same as desloratadine, okay? The antihistamine one are the ones used for the allergies. Remember, very important. But now we are not talking about allergy. We are talking about antihistamine 2. One, allergy. Two, we're talking about ulcers, gastric ulcer. We're talking about GERD, right? So when you see desloratadine, when you see loratadine, they end with the tidine, but take them off the list. They are not for allergies. Well, they are for allergies, I meant to say. They are not for ulcers. They are not for GERD symptoms, right? So one thing, safety precautions, why are we even talking about this is because the NCLEX loves to ask about the safety possible effect of the histamine 2 inhibitors, which is the agranulocytosis. It just goes to talk about infection rates that increases the risk for infection because it reduces the neutrophil counts. The other thing is gynecomastia when men develop breast is a side effect of this medication. So let's go forward. Neutrophil, when you see neutrophil, when you see agranulocytosis, these and the white blood cell, these are terms used interchangeably in the NCLEX. So try to connect agranulocytosis, neutrophil, and white blood cell into one, right? Okay, so list of drugs. Cimetidine causes the same effect as theophylline. I think these are the things you need to know, but let's talk about nursing intervention on this medication. Do not give at the same time with antacid. We've already talked about antacid that they are to be given alone because if you give with antacid, it interferes with the absorption. And then the best time to give antacid. Oh yeah, I have talked about antacid before, so I'm not going to be talking about it. Let's move to the proton pump inhibitor. I think what you needed to know about the antihistamine is trying to support the one that is antihistamine 1 and antihistamine 2 because of the endings. And the other one is knowing that there is side effect of gynecomastia, men developing breast, and also agranulocytosis, that's low blood count. So you may have to teach the clients and teach them also the neutropenic precautions, no flowers, avoid infection, and all those things. So the proton pump inhibitors, they end with the prazoles. So they suppress gastric secretion by inhibiting the hydrogen potassium alpase enzyme. NCLEX, I love them about this, will not be asking you the mode of action, but they will ask you how to spot them. When you see the medications, you should be able to say, oh, this is proton pump inhibitor. That example is pantoprazole, esomeprazole, omeprazole, lansoprazole, and all that. So, precautions, nursing responsibility. Acid suppression prevents pathogens from easily colonizing the GI tracts. If they are suppressing gastric secretion, gastric acid is not being secreted, it means that there'll be risk for infection. It is the same thing as the H2. That's why we're talking about infection. Acids, they actually help to prevent bacteria from really colonizing the whole GI tract. But when it's being suppressed, then there is high risk for infection. So, increased risk, there's also increased risk for C. diff, so associated with diarrhea, and there is increased invasion of microorganisms. Okay, these are short things I wanted you guys to know, but remember that the proton pump inhibitor should be given on empty stomach. Very important. This is what I tell my clients: take this for better effect. Take this once you wake up in the morning. They can actually keep it at their bedside so that by the time they wake up, they just drink it. And these medications, if you know the pantoprazole, omeprazole, they are this tiny white one. They cannot be crushed. They are not supposed to be crushed. They are supposed to be metabolized, used, readily available in the GI tract, not from the mouth. So they should also be taken, which is what I said, before meals, and it is important to monitor the liver function. We will talk about the liver function in a minute. I think that's the next thing we'll be talking about. I did mention I wanted us to talk about the statins because these statins are very important. Let's talk about the cholesterol lowering medications. Then we can talk about the um, liver enzymes, liver tests you need to know. Now, when we talk about the statins, they are the cholesterol lowering agents, cholesterol lowering medications. They lower cholesterol, they lower triglyceride. And one thing you know about cholesterol is that there is a buildup in the blood vessels, and that's why it is imperative we talk about this, because high chance of people dying from high blood pressure, and the high blood pressure could be that the cholesterol just get on the walls of the blood vessels, narrowing the path leading to which is now manifested in the high blood pressure. So yes, they can cause plaques. That's fat deposits. And we know fat deposits. So they are used for atherosclerosis and the coronary artery diseases. Yeah. So NCLEX may ask you about this lipid profile. One thing I use, this is one thing I learned from the High Yield Instagram page. He talked about um, the levels in a way that you easily remember. He said that the memory trick is that assess it or remember them according to the letters. So we have four. We have the HDL, which is the good cholesterol, the high lipoprotein, right? Then we have the LDL, which is the bad. It's low, it's below. Remember, low lipoprotein, it's the bad protein. And then we have the triglyceride, that too is bad. And we have the total cholesterol. If you arrange it alphabetically, remember, HDL comes first, followed by LDL, followed by what? Triglyceride and total glyceride. So remember them in 50s, right? So the HDL, which is the high cholesterol, which is the high density lipid, it should be more than 50 for you to say the body is doing well, the cholesterol is doing well, is doing what it needs to do, is protected. It should be more than 50. But every other one should be less. So in the low density lipoprotein, this is high density lipoprotein should be more than 50. Low density lipoprotein should be less than 100. Triglyceride should be less than 150, and total cholesterol should be less than 200. It's just simple, right? 50, 100, 150, and 200. 50, it should be more than 50. Low density, high density lipoprotein, which is the good cholesterol. Then the low density lipoprotein, less than 100, triglyceride less than 150, total cholesterol less than 200. And there you have it. You're ready to ace the NCLEX. Okay, so example of these statins are atorvastatin, simvastatin. Yeah. Now we are going to talk about the liver function test. There are two tests you need to know. In Finland, we have the ALAT and the AFOS. But I think in the US, in Canada, and other English speaking parts, we have the AST and the ALT. The AST is the aspartate aminotransferase. I'm going to say that again. Aspartate aminotransferase is the AST, and it is the way, like when you're doing blood tests, this is the test you're going to write. Aspartate aminotransferase, the level is about 10 to 14. And then the second one is ALT. Remember, which is the alanine aminotransferase. Aspartate and alanine, and the ending is the same. That's the surname is aminotransferase. So before starting any cholesterol lowering medication, it is imperative to check the AST, the aspartate aminotransferase, and the alanine aminotransferase. This is to monitor the liver function throughout the medication. So once you check first, you have established a level, a baseline, right? After that, you can now give the medication and continue to check. If there is a difference, then you know how to act. Now, one thing about the statins, that's the cholesterol lowering medication, is that they should never be given with grapefruit juice, because grapefruit block the enzyme that metabolizes these medications. Also, calcium channel blocker should not be given with statins. Always remember to monitor the liver function, aspartate and alanine. Okay, so one thing that we should remember about this statin is that they can actually cause muscle weakness, which is a side effect, a very good side effect. So if your client comes and they are complaining of my leg is hurting, my calf is hurting, and all that, check if they have statin, because it is one classic manifestation of this medication. Yes, so I think that's it for the statins. And when you're checking the muscle weakness, one thing you will see is the creatinine kinase. It is the protein, the enzyme released during muscle breakdown that occurs when you give statin. And this is not just in statin; it is also used as it is also part of the cardiac biomarkers. We have the troponin that talk about or a trustworthy test for myocardial infarction, troponin, RNT. The other one is creatinine kinase. When there is muscle breakdown, you will see this, but it is not like creatinine kinase. It doesn't really tell you if it is a heart muscle or what muscle. It just tells you that there is a muscle damage, right? But if you want to be very sure, like Nclex ask about this all the time, if you want to be very sure, myocardial infarction, then you know that the troponin is very important. My battery is low. One thing about the creatinine kinase is that there is the value is about 30 to 170. Morning lab could show creatinine kinase of 100 or 10 times the normal value, then confirming that there is rhabdomyolysis, that's the muscle breakage. A high level of creatinine kinase is an indication of muscle damage. Now, one thing about how do you even know, apart from the lab test, is that when a client is on this medication, the statins like simvastatin, atorvastatin, they may actually have this unusual colored urine, like the dark colored urine, showing that there is muscle damage. Okay, so statins, they are given at night, like especially the atorvastatin, they are given at night. I know that the simvastatin here in Finland, not necessarily at night, because cholesterols are synthesized during the fasting states, which is at night when people are not eating. So nursing intervention diets, you teach clients to have diet that is low cholesterol, fat. You should monitor cholesterol level, which is the aspartate. Cholesterol level, this is not aspartate, that's the cholesterol level I'm talking about are the lipid profile, the low protein, the high protein, high lipoprotein, low lipoprotein, triglyceride, and total cholesterol. These can be checked. Then the other one is the liver function, which is the aspartate and alanine aminotransferase. Also check the renal function, that's the kidney helping to excrete, and monitor if there is any muscle pain or muscle weakness. Now, the urine can also be checked. If there is any unusual color, which is dark colored, then you're like, okay, I'm suspecting something. I will go on to talk about the antipsychotic. Let's do that. This is very important. Like if I'm not doing anything, I need to talk about antipsychotic. Now, for the antipsychotic, we have two types. We have the atypical and the typical. Now, take your notes and let's talk about the typical. The typical, we have two types. We have the phenothiazines and we have the butyrophenones. One thing that I did during my NCLEX preparation is I would write about these medications every day on a book, on my parking. I used to work in a place where I would drive and park. So on the parking paper just behind, I was just writing. I'll write atypical, I'll write typical, under typical, I'll write phenothiazines, butyrophenones, and then under that I mentioned the type. So one thing about these phenothiazines, which is the typical antipsychotic medication, is that they relieve symptoms of psychosis, as well as apart from the psychosis, there is also relief in nausea and vomiting. In Nigeria, there is this Phenergan they give to people that is for the function of relief of nausea and vomiting. So they are antipsychotic, they are antiemetic, and they are also major tranquilizers. So they are sedative in nature. So example of these phenothiazines that we have the promethazine, we have the fluphenazine, hydroxyzine. But then the ones that I use for antiemetic against nausea and vomiting are the promethazine and the compazine. So promethazine are the Phenergan, and then we have the prochlorperazine. Then we're going to go to the butyrophenones. Hopefully, I'm pronouncing this well. butyrophenones. So they are used in treatment of schizophrenia and to relieve psychosis symptoms. Now, the phenothiazines, yes, are used for nausea and vomiting, but butyrophenones, they're also used. So both of them, they used to relieve antipsychotic, they are major tranquilizers, they are antiemetic. But how do you know the difference? In these butyrophenones, you must have seen haloperidol. You must have seen benoperidol. They end with the dols, right? So side effects of these very typical antipsychosis is the agranulocytosis. Remember, neutrophils, white blood cell, and then we have orthostatic hypertension. We have the neuroleptic malignant syndrome. Now, the neuroleptic malignant syndrome they ask that a lot. It is just related to fever in an elderly person with this typical antipsychotic. If they complain of fever, your mind should just go straight to neuroleptic malignant syndrome. And we're going to talk about that in a minute. And then the other one is the extrapyramidal effect. So the neuroleptic malignant syndrome is when it is a life-threatening reaction to antipsychotic medication, especially when they have haloperidol, droperidol, or phenothiazines, that is the Phenergan, chlorpromazine, and all that. So they have fever, altered mental state, or if there is muscle rigidity. But one thing the NCLEX test on, one thing that you will think of if there is a fever in an elderly client that has antipsychotic is neuroleptic malignant syndrome, which is characterized by this fever. So, but it's not just fever, but the other ones, but fever is usually a classic manifestation. So, there is also part of the neuroleptic malignant syndrome. Another manifestation is sweating tachycardia, which is part of the autonomic dysfunction. Okay. The importance of this question on NCLEX is fever of at least 101, which is like, or a low grade fever, is a warning sign of neuroleptic malignant syndrome. Is on its way. So consideration, you have to monitor the patients closely. And one thing that you're measuring for is the fever, right? Nursing intervention for this neuroleptic malignant syndrome is, first of all, discontinue whatever is causing the problem. You cannot be giving and giving when someone is dying. So you stop that. You implement measures to reduce fever. You can give Panadol to reduce the fever, tepid sponge, give IV fluid. So the agranulocytosis refers to deficiency of the blood cell, the low blood, yeah, of the white blood cell, the one that fights infection. So one thing you should do is, because they are susceptible, you need to monitor them closely. But that this one is rare, so NCLEX does not really ask like in detail. But one thing you should remember in this antipsychotic is the malignant syndrome. So the extrapyramidal effect symptoms are dystonia, that's continuous spasm, akathisia, that's motor restlessness, Parkinson's disease like bradykinesia, slow movements, rigidity. Then the other symptom is tremor, tardive dyskinesis, that's irregular and jerky movements. Okay. Then the last side effect of these typical antipsychotic is orthostatic hypotension. Just like we mentioned in the blood pressure medication, this is also part of it. Okay, I think this is all for the antipsychotic I wanted to mention about. Now we can go to antidepressants. So the antidepressants, we have actually two types. We have the first generation and the second generation. Antidepressants block or inhibit the reuptake of neurotransmitters. And these neurotransmitters, they are mentioned in the name of these medications. You're going to find that later. You're going to see that. So we have the two types of let's talk about the second generation antidepressants. And the names, I think you can you can slow me down, you take a pause, but you need to write this. This is part of the second or new generation. But I need to mention something. We have first generation and second generation. The second generation, they are like the new school, and they are like the atypical antipsychotic. They are manufactured because the first generation, which we're going to be talking about, like the monoamine, the MOAs, and all that, they have lots of symptoms and they have so many precautions, food not to eat, and all that. But this new one, the second generation, they are better. They have less side effects. So that's why we'll talk about them. The first one is selective serotonin reuptake inhibitors. That's the SSRI. The second one is serotonin and norepinephrine reuptake inhibitor. That's the SNRIs. Norepinephrine and dopamine reuptake inhibitors. That's the NDRIs. Serotonin antagonists and reuptake inhibitors. That's the SARIs and the tetracyclines. So, according to their names, it shows the kind of neurotransmitters they are inhibiting. So the serotonin selective serotonin reuptake inhibitor, which is a type of the second generation antidepressant. Examples are the citalopram, escitalopram, fluoxetine, paroxetine, aripiprazole, and brexpiprazole, sertraline, and fluxosamine. So they end with lopram, fluoxetine, fluoxetine, and the piprazole. They also end with INA, like the sertraline. Okay. Then the other one is the serotonin norepinephrine reuptake inhibitor. There we have medications like duloxetine, then the venlafaxine, and desvenlafaxine. Okay. These medications are also, apart from the antidepressive property they have, they also help to relieve chronic pain. These are the serotonin, norepinephrine reuptake, serotonin, and norepinephrine reuptake inhibitor. Now we'll go to the third type of the new gen, second new gen antidepressant. We have the norepinephrine and dopamine reuptake inhibitor. And in this, we have only one, which is the bupropion. Bupropion. These are actually mouthful words. Then we have the SARI, that's the serotonin antagonist and reuptake inhibitor, which are the nefexadone and trazodone. Trazodone. Trazodon. The end with zodone, nefazodone, trazodone. Then we have the tetracyclines, which is the last one, which is example of this is mirtazapine. You see medications on this. You see clients with this tetracycline, mirtazapine, asamoxapine, and the maprotilene. So you can actually write all these medications down under the second generation antidepressants. But the side effect of this second generation antidepressant is the A, B, C, D, E, and S. A meaning anticholinergic, dry mouth, and fluid retention, right? Then the B stands for blood vision, the C stands for constipation, D stands for dizziness, E stands for extrapyramidal effects, and then the S there is the serotonin syndrome. Now, key side effects for this that is classic for second generation is the serotonin syndrome. Serotonin syndrome is one thing that NCLEX may likely ask you about when they're talking about second generation. And let's talk about that, okay? In the serotonin syndrome is when the body does too much, like oversabi, too much excited. So everything is high, irritability, shivering, sweating, that's diaphoresis, there is diarrhea, there is muscle rigidity, there is restlessness, fever, seizures. Everything is just high in the second generation antidepressants. Classic manifestation NCLEX may ask you about is serotonin syndrome. Okay? So, in the typical antipsychotic, one thing that you need to remember is agranulocytosis, right? But in the serotonin syndrome, you need to remember antidepressants. Okay, I've written it with marks that you need to remember this because NCLEX loves to test on serotonin syndrome. Okay. Then let's go to the first gen. I want to end this video before 3 hours, but let's see how that will go. If not, I will finish it. The first generation antidepressant, they are the oldest antidepressants, and there are two in this. We have the monoamine oxidase inhibitor and the tricyclic antidepressant. Let's talk about the monoamine oxidase inhibitor. They affect the neurotransmitter by blocking the monoamine oxidase, which causes their breakdown. And this then causes increased level of neurotransmitter in the blood. But one thing that you need to remember about this example of this monoamine oxidase inhibitor is spit, like spit out. SPIT. The S is selegiline. The P is phenelzine. The I is isocarboxide. Isocarboxazide. ISOCARBOXAZIDE. And then we have the tranylcypromide. Then the tricyclic, which is the other part of the first gen, the other type, we have two: monoamine oxidase inhibitor and the tricyclic. They block reabsorption of serotonin and norepinephrine back into the nerve cells. So example of these are the amitriptyline, nortriptyline, imipramine, and desipramine. Okay. Yeah. Interactions. Very important that drugs do not take antidepressant together at once. So you cannot take the escitalopram, that's the selective serotonin reuptake. That's part of the second gen. You cannot take second generation antidepressant with first generation antidepressant. So you cannot take mirtazapine with any of these like phenelzine. Never. So do not take first gen with second gen. Do not take any of these antidepressants together, or do not give in this case. And what's the reason? To avoid serotonin syndrome, excitability, muscle rigidity, restlessness, diaphoresis, excess sweating, and all that. When change is necessitated, give 2 weeks break before starting a new medication. So if they stop a medication, antidepressant today, they have to wait until 2 weeks before they start a new antidepressant medication. Now, do not give the monoamine oxidase inhibitor with nasal decongestants such as physoephedrine or sulfifed or stimulant, because they could lead to hypertensive crisis. Yeah, so one thing you should remember about this monoamine oxidase is the side effect that the NCLEX may ask you about is hypertensive crisis. For the serotonin syndrome is antidepressants. Remember, generally all the antidepressant, but one thing classic side effect for the monoamine oxidase inhibitor, phenelzine, selegiline, is hypertensive crisis. But for the atypical, we have the agranulocytosis. Remember, then the typical antipsychotic is the malignant neuroleptic malignant syndrome, which is characterized by fever. So drug and food interaction, this is common with monoamine oxidase inhibitor. Now, these things I'm saying, they are very important. I'm only telling you things you need to know for the NCLEX. So I hope you really know these things, because NCLEX, they love to ask those questions that are very deadly. So monoamine causes breakdown of neurotransmitters. Yes. So tyramine containing foods are and monoamine is a no-no. Now, the tyramine containing foods, I have a memory trick, which is the Barochay, Barochay. Baroc, B there is for banana and beer. They should avoid that when they are taking the selegiline, phenelzine, and all that in the monoamine oxidase. They should avoid A, there is avocado, R is raisins, red wine, the O is organ meat. They should also avoid chocolate, avoid smoked meats, avoid hot dogs and other associated meats, aged cheese, not just all cheeses, but aged cheese and yogurt. Now, NCLEX tip I have written is that antidepressant medications take time to see effects. So you can tell the patient that the patient may come to say that it's over a week since I started this medication, Why is it not working? Tell them that it takes about a week. It's not a week, it takes weeks or even months for the effects to start. Antidepressants cannot, like the steroids and opioids and all that, they cannot be stopped abruptly. They should be tapered off to avoid withdrawal. Now, you have to watch out for signs of suicidal ideations, especially when they've just been prescribed to adolescents and adults. Very important, because there are, when the antidepressant come, it energizes them to carry out the ideations they've been having. So when these antidepressants are started, it is very imperative that you continue to monitor them, especially when they have just started it. And do not take over the counter drugs with antidepressants. This is patient teaching. Do not take antidepressant with St. John's wort, a herbal medication used to treat depression. Two antidepressants cannot be used, and they should be administered in the morning, as sleep problem is common with antidepressants. Sexual dysfunction is also another part of this side effect of antidepressants. Okay, so I think these are all for the antidepressants. Um, if we have some time, we could quickly look at our insulin. I think we should end with insulin. Let's end with insulin. Diabetes mellitus, diabetes insipidus. So diabetes mellitus is problem with the glucose metabolism. We know that in diabetes 1, that's usually like started from a young age, adolescent, and diabetes 2 is usually for the older people. We started with people that, like, it's not at the beginning. Now, diabetes 1 is for actually when the pancreas is not producing enough insulin. But then diabetes 2 is as a result of lifestyle. It's not like is not produced, but there is this resistance. So usually diabetes 2 is associated with older people, not like elderly people, but adult kind of diabetes. But diabetes 1 is usually for younger people. Now, diabetes insipidus, even if it is diabetes there, it is not the same as glucose problem. It is not a glucose problem. It is water problem. So in this, there is everything you have in diabetes, which is polyuria, polydipsia, but it is not like glucose problem. It is just the fluid part, right? So question is about low urine output or high urine output. Similar to DM, DI has a high urine output. They go to pee all the time, and that is why they have to replenish the water they are going to put out with the polydipsia. That's why they have the thirst. So what is the opposite of diabetes insipidus, which is it is the syndrome of inappropriate antidiuretic hormone. Everything about this antidiuretic hormone, right? In the antidiuretic hormone, the side is dry inside. It keeps water inside. So while in the diabetes insipidus, all the water is going out. It's like very generous with giving out the water, but then as it's given out, it needs to take more. So you see patients going to pee. I actually took care of one client. Every time you visit her, then I was working as a home care nurse. Every time you visit her, she's going to pee. Like during a 20-minute visit, she's gone to pee like 3 times. And every time she has water, it is the condition. So DM has polyuria, polydipsia. Therefore, DI also has polyuria, polydipsia. However, the syndrome of inappropriate antidiuretic hormone has is without or comes with oliguria. That it's stingy. It keeps the water inside, so it's like dry inside. and there is no thirst, right? Because it's holding the water. So because it's holding the water, there is low urine output. And then the specific gravity then will decrease because of water retention. But then the urine serum, now very important, serum specific gravity, that's the blood specific gravity is low. But urine specific gravity in SiADH is what? High. So nursing diagnosis, lot of urine retained is SiADH, but when there is fluid volume deficit because they are giving out the water, they're like Keziah giving out the water, then we remember the diabetes mellitus or diabetes insipidus. Okay. So diabetes 1 is insulin dependent, juvenile onset, and they are prone to ketosis. So they are prone to DKA, that's the diabetic ketoacidosis. Then diabetes 2 is non-insulin dependent, usually starts by adults. Yeah, that's what I said, and they are non-ketosis prone. Okay, so treatment of diabetes mellitus, that's type 1, is one memory trick is die. They will die if you don't treat them. So the D there is diet. Calories from carbs are very not really, really important. But insulin is the most important in diabetes 1. And of course, you can encourage them to exercise. But treatment of diabetes 2 is DOA. That's now the diet comes first. Check the kind of diet they eat, and they take oral hypoglycemic like the metformin medications. And of course, activity, encourage them to exercise. Diet for diabetes 2, because diet is the most important thing for diabetes 2 or adult onset diabetes mellitus, is the primary treatment is calorie restriction. So 1,200 calories and all that. This patient needs to eat 6 small feeding per day, smaller ones, but frequent. It means that as they do that, it keeps the blood sugar more stable. So, question: what is the best dietary action in diabetes 2? Do you restrict calories or you divide meals into 6? The answer is what? Because patients can eat 6 meals, they don't need the but does not limit the calories with it. So you restrict calories, because the right answer is restricting of calories, because you can tell them eat like 6 meals, but if they are overeating, it is of no use. So restriction of calories is the most important. Now, insulin acts to lower blood sugar. This is where we're going to stop. And insulin is very important. Please, you must know insulin for your NCLEX. You must know it. While I was doing all my preparation, insulin was something they really talked about. You must know. So we have 4 types covered here. We have the regular, which is the clear solution given IV. And please write, one thing you should know about these ones is the onset, the peak duration, right? Onset, peak duration. And this lesson is very easy. The pattern for regular insulin is 124. The one is onset 1 hour, peaks in 2 hours, and the duration is 4. Now, you have to pay attention to the peak. That's the highest level of insulin in the blood. Then we have the NPH, which is the intermediate insulin. And this intermediate insulin, it is cloudy, so not so clear, fast. Cloudy suspension, it precipitates, and you can't give it to I can't give IV drip, not so fast and not in the bag. MPH cannot be given in IV. In fact, the regular insulin is the only one that can be given in IV. Very important to know. If you're talking about giving insulin administration, the only one that goes IV is the regular insulin, okay? So the onset is 6, 8, 10, 12. So Onset 6 hours. No, the pattern I meant to say is 6, 8, 10, 12. Onset 6 hours, it peaks between 8 to 10 hours, and then the duration, how long it lasts, is 12 hours. So the pattern here is hear the evens and pay attention to the peak. The even is 6, 8, 10, 12, starting from 6 to 12. 6 is the onset, 8 to 12 hours is the peak, and duration is 12 hours. So clear solution, cloudy suspension will precipitate, not giving over IV or put in a bag. That's the MPH. Question: how would the board ask question about peak of insulin? For instance, you give 30 units of insulin to a patient at 7 a.m. When do you check for hypoglycemia? This doesn't say which one. So let's see. Answer. Add the insulin peak time to the time of administration. For instance, if it is MPH and you give by 7 a.m., add 8 to 10 hours to that time. So it means that you need to check for hypoglycemia around 3 to 5 p.m. It's the same with the regular insulin. You can add, in our peak for regular insulin is 2 hours, right? That's it, 2 hours. So if you've given by 7 a.m., when next should you check for hypoglycemia? 9 a.m., right? So Lispro, which is the Humalog, this should not be given before meal. Lispro, very important because it's like fast acting insulin. This is the type that you say seafood. If the food is not there, if someone is telling you, give the patient the insulin, I'm going to bring the medication, don't hold it. Because the onset is 15 minutes, before you know, it peaks at 30 minutes and duration is 3 hours. So 15:33. Okay. So Lispro, when you have the food there, then you can give. Do not give if you don't see food. Lispro seafood, Lispro seafood, whatever you can use to remember it. Then we have the Glargine, which is the Lantus. It's the long acting, there is no peak, but then the duration is half a day to a full day. And there is little or no risk for hypoglycemia. Okay, what action invalidates the manufacturer's date? When you open the package, if the manufacturer says that it expires in 2 years' time, as long as you've opened the package, then that expiration date on the pack is no longer valid. Once the package is opened, the new expiration date becomes 1 month. That's 30 days after it's open. So open the package. If you open the package without an opening or expiration date, if you open the package and there is no expiration date, then you throw it away. Do not use that. Label the package either with open or date package is open and expiration date. Once the package is open, refrigeration is optional. However, unopened bottle, unopened package must be refrigerated. That's why some of my clients, when we go to give them insulin, the one that are unopened are usually in the fridge. But then once you start giving them, you can just leave it in normal room temperature. Okay, so exercise potentiates, very important. Exercise potentiates, increases insulin action. So exercise is like another shot for insulin. Therefore, if a student is scheduled to play soccer or exercise this afternoon, it is necessary to decrease now you're decreasing the dose of insulin. In addition, the school nurse must give the student rapidly metabolized carbohydrates like snacks or juice. So for sick days, what do you do? Patient has a fever or flu and all that. It means that on sick days, remember what we talked about steroids, that stress goes high. So serum glucose level goes up. So they need their insulin, right? Even if they're not eating, there is hyperglycemia because of stress. Take sips of water because they may get dehydrated. And any diabetic patient has two problems: hyperglycemia and dehydration. Okay. Acute complication of diabetes, low blood sugar, hypoglycemia, hypoglycemic shock, insulin shock. Why are some of the causes? Or the causes of this hypoglycemia is they are not eating enough food, or the insulin is too much, or too much exercise. Insulin and exercise, they are the same thing. So, what does hypoglycemia look like? Think drunk patients in shock. So, drunk is like staggering gait and just slurred speech. You cannot even really understand the speech. Cerebral impairment, slow reaction time, decreased social inhibition. But in shock, there is tachycardia, tachypnea, low blood pressure, cold, clammy, and more to scare. Then, very important for the treatment of hyperglycemia, it depends on the client. If the patient is cautious, not cautious, but conscious, like alert, then you give orally. So, give patients rapidly metabolizable carbohydrates like juice, candy, ice cream, jam, and all that. But then the NCLEX want you to give sugar, starch, and protein, not just sugar, but a combination of sugar, starch, and protein. For example, you can give apple juice, you can give turkey, you, you can give milk, skimmed milk. So a very bad option is when you say candy plus sugar. Candy is sugar, soda is sugar. So yeah, one sugar is good, but two sugars are bad. 5 packs of sugar emptied into an orange juice bad. But then in an unconscious patient that is hypoglycemic, then you give glucagon. Okay, if the patient is at home and they have glucagon, they just put that, give intramuscularly. And if it is in the hospital, then we can give dextrose IV. Then we have the diabetic ketoacidosis. That's high glucose in type 1. Keto is the clue. Remember, ketoacidosis is more in type 1 diabetes, not in type 2. And the cause is too much food, not enough insulin, and not enough exercise. Signs and symptoms of this is dehydration, dehydration, that's poor skin, ketone. Ketones is in serum, that's ketone in the blood. Kussmaul, that's the rapid breathing. And then there is hyperkalemia, high potassium, over 4.5. There is also acidosis, there is acetone, there is this fruity smelling breath. Then anorexia due to nausea. Note, ketone in the urine does not necessarily mean diabetic ketoacidosis. Very important. So how do you treat this? You give IV because it's too much food but little insulin or little exercise. So there you go. You have your answer. You give them insulin IV. And in this case, remember the only insulin we can give? Regular insulin. That's the only one that goes IV. And of course, you give them fluid because problem with diabetic ketoacidosis is they have hyperglycemia, and then they have what? Dehydration. So as you're giving them insulin, also give them fluid. Through the fastest one, like 200 mils per hour. Then the other one is HHNK, HHSH, and all that. This is high blood sugar in type 2 diabetes. These patients don't burn ketones, no acid. So whenever you see HHNK, think dehydration. Severe dehydration, and that's the skin is dry, flushed, decreased turgor, increased heart rate. And the nursing diagnosis is fluid volume deficit, same as dehydration. What do you do? It is simple. Give fluid, IV, by mouth, and all that. So between DKA and HHNK, which one is more dependent on insulin? We know the answer. That's DKA. DKA is more dependent on insulin. HHNK, patient just need to be rehydrated. Which one has a more has a higher mortality rate. That's patients with HNK die more. Which is a priority? Which is a higher priority? Well, DKA is a more acute condition and responds very quickly to insulin. HHNK patients show up late in the emergency room and do not readily respond to treatment. So, related to long-term complication of diabetes, there is poor tissue perfusion, peripheral neuropathy, and all that. Now, this test is very important to know. The HbA1c is glycosated HbA. The average, this is a test to check how the body is doing. So the hemoglobin, it's about checking for, it's a test for people that have diabetes. And it is done over a period of 3 months, not like every day, but 3 months. If it is less than 7, it is normal. But once it's out of over 8, it is out of control. But 7 is borderline. You need to like, okay, be careful. It's like yellow lights. Be ready to take action. 8 is red lights. Green, 6 is green. Okay, everything is fine. So yeah, thank you so much for watching today's video. Please do me a favor, click on the like button, share this video to somebody, click on leave your comments. I will come back and do another video. This is the second part of the NCLEX review. We have 3 more to go, except you guys tell me after the 5th one I should go on. But these are some of the things I want to share with you guys that really helps, that you need to know to equip yourself. So thank you so much for watching today's video. I am going to put these videos I'm making about NCLEX review in a playlist. So if you've missed the other one, you can see the playlist on NCLEX review and watch the rest. And yeah, thank you so much for being here. In the description, you will see other videos. You will see other videos, my NCLEX strategy, my personal question that I use to pass the NCLEX, and a lot of links to find freebies, to find more downloadable resources. And yeah, keep going. It is not easy, but you can do it. Just keep going. Take it one day at a time. Remember to believe in yourself. Write affirmation. I actually write affirmation. I have passed in my first NCLEX when I was preparing, and it worked out. So write it down, make it plain, so that he that sees it goes to bring it to pass. That's God's word. Claim God's promises over your life and keep going. And thank you so much for being here. And we're going to see you. I'm going to see you in my next video. Bye for now.